All right, so welcome everyone. Thanks for joining us. I know we'll be getting a couple folks coming throughout the afternoon as clinics slow down, but we're so excited that for this year's Paton Lectureship, we're able to have one of the people I think has influenced global ophthalmology more than just about anybody else on this earth. And Dr. Prajna, Dr. Venkatesh Prajna, comes to us from Aravind Eye Hospital. Now, of course, the name precedes it. Aravind is well known throughout the world, both in ophthalmology and in healthcare in general. Dr. Prajna, he completed his MBBS from Madurai Medical School back in 1989. He did his residency at Aravind, where his parents were some of the founding members as well, and his family is deeply tied to the success of Aravind. He joined staff at Aravind in 1993 and has been on the Cornea service ever since then. He was named head of the Cornea service about 10 years ago, where he's directed them to great success, both clinically and also academically. He has extensive research in corneal infectious keratitis, also in a number of other specialties, but he really pushes forward the academic prowess of the hospital system as a whole. He's been the academic director of Aravind, and he oversees a residency program now of, is it 200 residents?
120.
Sorry, 120 residents, which regardless is an enormous residency program, and has really reshaped the entire ophthalmic community of southern India and India at large. He oversees all of the international trainees, and to date there has been over 800 US surgeons who have been trained to some extent at Aravind hospitals. It's truly impressive. He's on the advisory board for JAMA Ophthalmology and has published over 150 articles. He's also the chief editor for Payments Principles and Practice of Ophthalmology, and now in his robust free time, he is also the finance director of Aravind Hospital Systems. So there is so much for us to learn from him, both professionally, academically, and from a public health standpoint, that I am so grateful that we have these hours to learn from you, Dr. Prajna. So thank you for joining us, and please give a warm welcome to Dr. Prajna.
Thank you very much. Okay. Thank you very much, Brent, for the very kind introduction. It's indeed an honor for me to come to one of the most prestigious institutions in the world, Wills Eye Hospital. It has been a dream come true for me. This is my first visit to Wills, and I wish to thank the faculty, the head of the department, and also the Department of Global Ophthalmology for this kind invitation to be here with you. So what I'm going to talk is I've never had the opportunity of holding the podium for 3 hours. So it's going to be a challenge for both of you, but it's going to be a bigger challenge for me. So I have 3 talks here as a clinician and who has worked extensively in the field of fungal keratitis. I'll be sharing about my experiences in our research work on fungal keratitis. The second talk, I would be talking about the eye care service delivery model, our experience with vision centers, where we use telemedicine, and close to around 2,000 patients every day are seen through telemedicine. And the third part would be on the training part, where I've been instrumental in administering these training courses at Aravind Eye Hospital. But before I start, I would like to acknowledge the presence of my mentor, Dr. Alan Robin, who has come all the way from Baltimore just for my talk. And he's seen me from my school days, pushing us, all of us at Aravind, towards doing something useful, something beyond just surgical carpentry, asking us to focus on research and Alan, we are very, very grateful not only for your presence today here, but also for all the mentorship you have been providing us all these years. So let me talk about our work on fungal keratitis. And I would like to remember Dr. David Paton today, in whose name these talks are going to be. We all know Dr. Paton as the person who started Orbis. He had a very distinguished career, started off at Johns Hopkins, is the chairman of Baylor, first director of Culinary Institute, played a major role in Project Orbis, and then he was also the first chairman of King Khalid Eye Hospital in Saudi Arabia. Now, this person had really a lot of varied interests and could make a lot of difference in many people's life. In 1986, he was also the chairman of CMC at New York, and he also had some foundations. And finally, in 1991, he's the founder of OWSP, that's One World Sight Project. In November 1987, he received the Presidential Citizens Medal in an Oval Office ceremony. And in September 1988, he was made the Chevalier in the French Legion of Honor, the highest award a French government gives to overseas citizens. I had also the fortune, I don't know whether he read the mail or not, Professor Martin Goldberg actually sent an email to Dr. David Paton yesterday saying that I was going to give this talk in his name, and it's indeed a double honor for me. So let me talk to you about fungal keratitis. While the world over, bacterial keratitis is more common. It's almost 10% in the US, but it's not true in Miami. In Miami, fungal keratitis is almost 35%. In bulk of the US, it's 10%. Africa is 38%. But in India, it's 55%. It has replaced bacterial keratitis as the most common cause of infectious keratitis. Why is it so common in places like India? India is an agrarian country where people don't believe in wearing any protective gear, whether it's COVID or whether it is agricultural work. They just like to be very brave and get into trouble, like abrasions followed by agricultural contamination, resulting in fungal keratitis. I was a founder member of this study, the Asia Cornea Society Infectious Keratitis Group. So we wanted to see whether this problem was only in India. And so we did a study in 8 countries: India, China, Japan, South Korea, Taiwan, Thailand, the Philippines, and Singapore, as part of the Asia Cornea Society. And if you see in totality, bacterial keratitis was more common than fungal keratitis. But if you see by countries, very clearly, India and China, the fungal keratitis was more common than bacterial keratitis. To put this in numbers, in India, it's estimated that close to 800,000 people each year develop infectious keratitis, out of which 55 to 60% are caused by fungus. So I'm lucky enough to be in a disease which is very prevalent and where we could make a big difference. And R&D should just not be research and development, it should be relevant and to make a difference. That's the first, I won't say a lesson, the first experience I would give you. Choose a disease which affects a large number of people, and then there you can really make a difference to their life, as I would talk to you in the next few slides. Today, actually, I'm going to confine myself to the studies which I have been involved in. So I'm going to talk to you about the work which we have done in diagnosis. I'm going to talk about the work which has already been done. I'm also going to show you some interesting way forward where I believe the future is going to be. Some thing on the management of fungal keratitis, where we have changed the treatment practice patterns across the world, and the lessons learned, which may be of some surprise to you. At least it was a surprise to me when I got to know this result. Diagnosis part. when you're presented with a textbook description of ulcers like this, it's a no-brainer. A feathery margin ulcer, you're often taught that it is going to be a fungal keratitis, and you're usually right. You don't even need a scraping. You don't even need a confocal microscope to find out that this ulcer was caused by a fungus. But the problem in real life is most of these microorganisms, as they often joke, they don't read textbooks, so they present in their own style. And here are 4 circular ulcers caused by 4 different organisms, each competing for the prize of the perfect sphere or a circle. We are always taught that circular ulcers means acanthamoeba. But here I'm showing you 4 circular ulcers caused by 4 different organisms. And unless you have a microbiology support to say, there is no way that you can confirm whether it is caused by bacteria or fungus. So we did a very interesting study which we published in 2012. We took 80 photographs and we sent it to 15 cornea specialists of Proctor Foundation and Aravind. These are not residents, these are not fellows, these are fully trained cornea specialists. And if we just showed them the pictures and then asked them to grade, 66% of the time they were right. That is slightly above chance. So even amongst the distinguished cornea specialists, it is not very easy to differentiate bacterial keratitis from fungal keratitis. So the only way to do it is microbiology. And most important thing, as a clinician, it's very important that you get the specimens right. Unless you're going to give the correct specimen, it's just like the computer industry, garbage in, garbage out. You have to really make sure what you're going to give to the microbiology is something which they can work with. And so it's very, very important as a clinician that you need to give them the correct sample from which they can work on light microscopy or fluorescent microscopy. But the studies which I was particularly interested in was on confocal microscopy. We used a HRT confocal microscopy for all our studies on the field of fungal keratitis. And these were my publications in 2016 to 2018, essentially looking on the organism, the corneal cellular changes, and the inflammatory cellular changes. First, about the organism. When we actually went into the study, there are interesting studies in the literature which says Aspergillus branches at a specific angle, Fusarium branches at a specific angle. So if you have a confocal microscope, you can differentiate between Aspergillus and Fusarium. We wanted to see whether it is true, and at these 3 things, whether there is any difference in the branching angle, whether there is any difference in the adventitious sporulation as reported before, or the dichotomous branching which was described before. No difference in the branching angle, because the microscope which we were using is current, is a laser microscope, much more accurate than the previous confocal microscopes. So there's no difference between Aspergillus and Fusarium. No difference with regard to adventitious sporulation, no difference with regard to dichotomous branching. In essence, with a confocal microscope, you cannot differentiate between a fungal ulcer, between a Fusarium ulcer and an Aspergillus ulcer. What about corneal cellular changes? Now things get to be of some interest. In the stroma, if you really see, there is a complete alteration in the stroma. Let me give you a broad picture of things. The way we are treating an infectious keratitis today is close to barbaric. We think we are killing the organism and we are saying that we are controlling the disease. It is not the right attitude at all. We are actually killing the organism and thinking that we are countering the disease. It's just like killing one terrorist and then thinking that we have taken care of the entire terrorism in the whole region. It doesn't work that way. What we need to work is at the interface as to where the organism and the host actually meet, And that is where you see interesting changes happening with the stromal reorganization and the stromal pulling of the anti-inflammatory markers in the cornea. There is definitely stellate interconnectivity, which is very distinct of fusarium, where you can definitely say that this is more likely to be fusarium than aspergillus. But interestingly, dendridiform cells, we always knew clinically that aspergillus ulcers were more virulent than fusarium ulcers. And we were thinking that aspergillus was more virulent than fusarium, but that doesn't seem to be the case. It is because the virulence is because there is much more of dendridiform cells or a much more of an inflammatory response associated with aspergillus than with fusarium. Now, why is this interesting is, in bacteria, we are very clear. Gram-positive bacteria responds to something. Gram-negative bacteria responds to something, some drug. But for fungus, we always say antifungals. We tend to put all fungals into one bracket, which does not seem to be true at all. There is a difference in the organism, but also among the inflammatory response to that organism. We extended it further, and we now went into a very interesting study. What I found out was the pulmonologists also have a big problem with fungus. And what they do is they have a very integrated system in Edinburgh, which included chemists, physicists, engineers, and all these people. And what they found was, if a patient is in the ICU, and if you don't really know the reason as to why they are in the ICU, whether it's due to inflammatory cause or whether it's due to an infective cause, what they can use is they can use some chemical probes, put it in a bronchoscope, spray it into the bronchus, and then see through a fluorescent microscope and see this fluorescing bacteria. So you're able to tell whether it is caused by an infecting organism or an inflammatory organism. If you really see, here everything looks similar, but if you see in this, you can see brilliant white sparkling gram-positive cocci, which is showering it. So we knew that the pulmonologists had some technology, which as ophthalmologists we did not have. And so we worked very closely with them. And we wanted to see whether this technology can be used in the field of corneal ulcers. And we used a probe, a chemical probe. When I didn't understand anything when they were talking of probes. They were telling me about probes, and I was thinking that they're going to hand me a glass probe. What they meant was a chemical probe. I didn't know. That was my knowledge about all this when I did this, when I'm doing this research. But what it does is, if you are applying this chemical into the smear, if it fluoresces green, it is gram-positive bacteria. If it fluoresces red, it's gram-negative bacteria. And if it fluoresces blue, it is fungus. You can alter the color, but it's something so easy, and you don't need a top-end microbiologist to detect whether it is caused by bacteria or fungus. So we published this in the American Journal of Ophthalmology in 2020, where we said that these fluorescent smart probes are much better than gram stain with regard to, as compared to cultures. Now you may wonder, why do we want to do something which is looking more complicated than a simple gram stain? We said it is more sensitive and more specific, but is that the reason why we want to change? No. We really believe what it can actually do is, forget these slides, let me just give you an example. Imagine a situation, you are applying a drop of a chemical into a patient's eye, and you use a fluorescent microscope, which we are now designing at a cost of around $4. So we are at that stage where we have a good manufacturing arm where we can develop a low-cost fluorescent microscope at $4 to $5. And so with that $5, we'll be able to say which organism is causing it. But very importantly, very, very importantly, for the first time, we are also demonstrating where there is heightened MMP activity, that also fluoresces in a different way. where there is a increased IL-17 activation, that also fluoresces in a different way. So you get a complete map by putting a drop or multiple drops into the cornea and using a low cost fluorescent microscope. So you not only are targeting the microorganism, you are also made to aware that which of the inflammatory markers are getting elevated so that you can treat it. What is more interesting is our collaborators in Edinburgh have shown that if in the same condition in the lung, if you apply a topical matrix metalloproteinase inhibitor, it really suppresses the matrix metalloproteinase activity. So 10 years from now, where we want to be is you apply a drop of chemical probes into the eye. It fluoresces, it tells you the actual pattern. Then you apply a drop of medicine into the eye, where the anti-infectives will actually go directly and go and kill the organism, and the anti-inflammatory part will go and directly suppress the MMP responses. Now today it looks like a fiction. I promise you that the future of infectious keratitis is going to be this. It is not going to be what we are using now, and so we'll just don't bother about these slides. These are a complicated slide, but I've just told you where the future is headed. But what we know is today, if I have a fungal ulcer, I'm treated with natamycin. If Brent has a fungal ulcer, he's being treated with natamycin. People will laugh at us 20 years from now that both of us were treated with natamycin. What we will be treated with will be, if I have a fungal ulcer, I'll be treated with natamycin P, where P will be a tag protein attached to the drug, which will go and alter my immunomodulatory response. And this is a slide which I put it much before all this probe business started to come. This was my thought process in 2010, and I was heavily criticized for it, because when you start to use the word immunomodulator in a fungal keratitis, you're actually shouted down upon. But when you have 150 publications, people now see it with slightly increased respect. But what really changed is the COVID. I should be really thankful to the COVID. What happened in COVID? When they started just killing the virus, the patients also died. But when they tried to play with the immune response, the patients survived. So when I now talk about immune response, I always allude to the example of COVID. Then people understand, so it's not a big deal. It is something which is plausible. So this is going to be definitely the future. The future is not about killing the organism. The future is about playing at the interface. So my next part with diagnosis is to do with the AI mechanism, where we now have an R01 grant with the University of Michigan, with the Kellogg University, where we demonstrated by a series of publications that when doctors measure corneal ulcers, if the patient comes on Monday, I measure a corneal ulcer, and the patient comes on Tuesday, if my associate measures it, it's different. And on Thursday, on Friday, my second associate comes and says it's healing. We just go by arbitrariness. So what we are actually trying to design is an instrument which is akin to an OCT. So before an OCT came, it was always a CSR was present or an absent. But now we know that macular edema is 500 microns. With treatment, it becomes 400 microns. With treatment, it becomes 300 microns. We have a quantitative measure. So this is the aspect of the project which we are doing with Kellogg and with Duke. The person at Duke, Dr. Farsiu, has a patent with Spectralis OCT. So we really feel that we are now developing a cornea scope in which you can give a quantitative algorithm, and we will also be able to predict when this quantitative algorithm is crossing a certain limit that this ulcer is doomed to fail. So this was like, for example, my first publication was in 2018, where we said image photography is better than doctor's measurement. Then in 2020, we came to a conclusion in this paper that a semi-automatic algorithm was developed. And with Duke, there's a lot of work. In fact, you had to actually detect something, and you have to also make the computer forget something, because for that computer, white is a white. Whether it's a Purkinje reflex, it's a white, or a stromal infiltrate, it's a white. So you need to really make it forget some things, and then do a series of tests. And what we now have a fully automatic algorithm, and we are now looking at around 4,000 corneal ulcer patients, both in Kellogg as well as in Aravind. And we are actually trying to measure and quantitate this. And just read the last line. We want to design an instrument like an OCT, which will tell us exactly whether the ulcer is healing or not, or where are we going with regard to this in the future. So that is my other interest in the field of diagnostics. So that completes my work with the sphere of diagnosis of fungal keratitis, which I really believe that the best is yet to come, and the best is going to be, what is going to come is going to be completely different than what we are used to. Management, I was a principal investigator in this study called the MUD trial, the mycotic ulcer treatment trial, where we compared natamycin and voriconazole. It was a randomized controlled trial on around 350 patients, where we said natamycin is better than voriconazole. Please concentrate on the title, which says for all organisms. That is the crucial part in this whole story. We said natamycin is better than voriconazole if you treat all organisms as a whole. But if you take fusarium alone, natamycin was much, much better than voriconazole. So the findings of the MUD study was not just natamycin is better than voriconazole in filamentous fungal keratitis. The most important finding in MUD study was different fungi respond to different antifungal drugs. Now that is again a very big new thing, because we always thought that fungus means antifungals, but here we propose that different fungi respond to different antifungal drugs. In non-fusarium cases, not much of a difference. So that means you really need to speciate before you effectively treat these patients. Very interestingly, any research has to be repeatable. Otherwise, it is not really respected. During a similar point of time, investigators at LV Prasad, when my results came out, it was a very difficult result to believe in. And they did another study where they said reappraised. And this was also published in BJO. This was also done on a large study of patients, a complete new set of investigators, also telling us that, yes, there is a difference between fusarium and aspergillus with response to natamycin, and natamycin is a much, much better drug than fusarium. We also found out that there was no benefit in adding oral voriconazole to topical antifungal agents for severe fungal keratitis. But what we were very intrigued was, why is voriconazole behaving this way? Because in 2002, voriconazole came off as a wonder drug in many in vitro studies. It was supposed to be the only drug to which drugs were acting and to which the infection was acting. But what happened was, over a period of time, natamycin is one drug which is used only for the cornea. It is not even used for in the vitreous. So the chance of developing a resistance is very low. But voriconazole is being used right, left, and center in the field of agriculture. So I sometimes, I don't laugh, but I take it with a pinch of salt when we try all our best to reduce antibiotic resistance. Do what all you do want to do, but you're not going to be successful, because in agricultural practices, the way they use these antibiotics, it's phenomenally high, and the bacteria don't know whether they are in the cornea or they are in the soil, so they develop resistance there. So my advice for you would be, treat your patient. If the patient is healing well, treat it. Don't worry too much about your antimicrobial resistance, because that individual patient at least can survive. So widespread agriculture was the reason by which from 2002, when we started the study in 2010, voriconazole became not a great drug as it was proposed to be. So before we did the MUD study, in 2007, we did a study across the Cornea Society. We asked them one simple question. If given a choice, which drug would you prefer? Would you prefer voriconazole or would you prefer natamycin to treat fungal keratitis? 80% said they would prefer voriconazole in 2007. 10 years later, we did a similar survey, and based on the results of our study, we were able to influence the world that 70% preferred natamycin, and there were multiple studies. Actually, I was also very lucky because I got a very controversial result. And I think when I published it, people didn't believe it as much. So they did a multiple reappraisal studies, and everywhere things started to come that yes, there is a difference. Yes, that difference is pronounced between fusarium and aspergillus. So sometimes you are lucky to be in a time where you are ahead of others. So that was about the medical thing in which I was involved. Then we wanted to see whether cross-linking is useful in the field of fungal keratitis. The problem with any technology for that matter is people get wedded with that technology and want to use it for all the purposes. They might try it for cataract surgery also. So you have to be very cautious when you get results like this. So there are two possible mechanisms. It appeals in one way because you kill the organism and you strengthen the cornea from the enzymes. So we wanted to see whether cross-linking works. We did two studies, but I'm going to concentrate only on the fungal keratitis study. I first published in 2015, where I said if you use cross-linking, the perforation is almost 4 times higher than if you don't use a cross-linking in a deep stromal fungal keratitis. I was widely criticized for this paper. In fact, Dr. Hafezi actually wrote a letter to the editor saying that these people have designed a study to fail because they chose deep stromal fungal keratitis, and if you do a cross-linking on those conditions, then there will be perforations. My logic was for superficial disease, you don't require a cross-linking. So only for a deeper disease, you require all this. And so we just did this, but we found out that fungal keratitis, especially it's more dangerous to do cross-linking. So when Dr. Hafezi raised that question, we said, okay, let's take all fungal keratitis. Let us not restrict ourselves to deep stromal fungal keratitis, and then see which is better. We had 4 arms in this randomized controlled trial. But the one thing you need to appreciate in this is when you do a randomized controlled trial of 300 patients, that means you have screened 2,500 patients. So you really need to have a very big cohort of patients, and you need a very rigorous study. One advantage of all the studies which I was doing in this was it was an NIH-sponsored study. There was a DSMC which monitored this study, and so and then one big advantage for this is it could never get better than this. Alcon donated natamycin for this study, and Pfizer donated voriconazole for this study. Both of them were very clear that their drug was going to be the wonder drug. So we got the best of the drugs. We got a very good DSMC monitoring us, and we had a huge patient population. And our study, and I'll show you in a subsequent slide, was asked to be stopped because the results had already been obtained by the frequent meeting of the DSMC. So to cut a story short, even if you take all fungal ulcers, irrespective of whether deep or superficial, the cross-linking does not seem to work. And now this is, again, I published this a year back in Ophthalmology, but then this is only with the riboflavin and UVA. But we are now trying out we are now doing a tripartite study with Bascom Palmer and Proctor, where we are trying to explore the Rose Bengal PDT to see whether cross-linking with a different drug works for fungal keratitis. So what are the lessons learned? Now we come to the interesting part of the whole story. These were all studies but there has to be some lessons learned. As I told you, one of the lessons is going to be personalized medicine. But what we also found out was there is a difference between different fungi to different drugs and all these differences. And let me show you one thing. So in our lab, in 2006, we published that aspergillus ulcers were different from fusarium ulcers because there was an increased risk of perforation. We said aspergillus and fusarium are different. But what we also found out was in the fusarium subset, 80% of the fusarium, what we saw was caused by fusarium solani. And if it is caused by fusarium solani, it causes much more denser scars. Amongst the fusarium, there seems to be a difference. Now, how do you understand this? This is again, we all know about pigmentation. We were taught in microbiology that if there's increased pigmentation, that means it is increased virulence. You can see the colors, it's all over the place. These were all the fusarium which were isolated from the mud study. So you had fusarium of different virulence. And the best way to understand this is to use this slide. Never forget this slide. Everybody in this group belonged to Homo sapiens, but their virulence factors is completely different. We know that, we understand that, but we don't apply that when we deal with microorganisms. So you just need to understand certain concepts to know that within fusarium there is difference. Between aspergillus and fusarium there is difference. Microorganisms are not as stupid as what we think they are. They have differences in the way they function. They can go into hibernation. They can spark up if they want to. And then your body's immune response also need to be adequately controlled. And this is another thing which we said. We told about the difference in the microorganism. But for the first time we showed that there is a difference in the immune response in the tears if the cornea was infected with aspergillus or if it's infected with fusarium. We looked at a protein called zinc alpha glycoprotein. We do a lot of proteomics work in our department. We found out that in Aspergillus flavus infection, the zinc alpha glycoprotein goes down. In fusarium, the zinc alpha glycoprotein goes up. Doesn't matter. What it just tells you is the human immune response, when it fights against different genera of fungus, the whole response seems to be different. For the immune response, it actually looks at as two different organisms. So, the crux of my talk is today. Today, we are actually countering fungal keratitis by killing the fungi. But that is not the place to actually play our game in. The place where we need to concentrate is this. We need to kill the organism, but we need to moderate the immune response. Just like COVID, we need to keep these kind of, the immune play in the whole system has to be taken into consideration. So what are the impacts of a study? The place where I come from is down in South India. Very difficult for you to make a global impact sitting from a place like that, especially in a disease of this magnitude. But see this slide and see the last line. Before the mud study came, none of the randomized controlled trials in the field of infectious keratitis, there was any difference. They were saying, oh, this is better, this is also better. But for the first time in the global literature, we were proving in a randomized controlled trial that there is a significant difference. We started off by having a sample size of 365. We were called by the DSMC to stop the study at 323 because the response was very clear that one drug was better than the other. That was a very fantastic moment where we could really define something and tell the world a new finding. Because what we say is not only relevant to ophthalmology, but it's relevant to pulmonology as well, when we say different fungi respond to different antifungal drugs. And it also resulted in so many publications. So these are my publications from 1997 to 2022 in the field of fungal keratitis, almost encompassing all these areas, right from epidemiology to confocal studies, clinical features. I'm really wedded to this topic. And it also helps that my wife is a microbiologist and an ophthalmologist. I need to make this disclosure because Alan would be watching whether I'm making a statement acknowledging my wife's contribution. I really want to make her, she's a very nice lady, she projects me, and but most of this work would not have been possible without her help. She has a dual degree. It's very difficult to work only with microbiologists, but since she had like 3 years of microbiology and 3 years of ophthalmology, she could understand what I was alluding to. And so we got a fair amongst a good publication list. And that was the clinical part, and this was all the basic science part, only in the field of fungal keratitis. But see also the span, right from 1999, we are interested, 22 years of research in one disease, but one disease which affects 500,000 Indians every year. So it really makes a lot of effort in our part. But the only request I have for you is you will definitely hear 10 years from now that the treatment of infectious keratitis will have an inflammatory and an infective component which is being administered simultaneously. When you see that, please remind yourself that you heard it 10 years before, that this was told to you, because I know that this is going to be the future. Cancer biology, or if you really see autoimmune diseases, have already employed this technology in a very big way. And I've convinced pulmonologists to come and work with me. They are from Edinburgh. I just said a simple logic. You don't know what is happening in the lung. You can see everything what is happening in the cornea because it is just external. It is like a laboratory on your face. So you tend to have all these kind of vocal things to attract people to come and get interested in this subject. So this was a study done by authors from China, which was published in Cornea. The title was Analysis of Global Research on Fungal Keratitis. You see right in the top is Lalita. Lalita is my wife's name. So we have the largest number of papers which have been published in the global literature in this field, and consistently so. And we really feel that the best is yet to come. During this time period, we have developed extensive collaborations with many institutions. In the US, we work with UCSF and Proctor, who have nurtured us from the beginning in this field of infectious keratitis. We also work with Bascom Palmer now, and we work with Pasteur Institute in Paris. We work with Duke, we work with Heriot-Watt and University of Edinburgh and University of Liverpool. So we have now strung up an alliances in the field of fungal keratitis. We started off by just looking at one small problem and seeing what we can do about it. But in a 22-year-old period, we have been able to really secure a global alliance. And we are now moving the WHO to make them understand and respect this disease and consider this as a neglected tropical disease. In fact, we have had 22 governments actually writing to the WHO to consider this just like onchocerciasis. Consider this as part of a thing. And I think it's our responsibility to do it. And then that will create a larger, much more awareness for this. Now, the proudest moment for me is this. At Aravind, our founder, Dr. Venkatesh, always looked up at Moorfields Eye Institute. He always used to say, we have to aspire to be like Moorfields Eye Institute. It was a very proud moment for me that after the MUT results were published, a special bulletin was actually made by the Moorfields Eye Institute, which actually determines what the NHS would do across the UK, saying that in view of this present results from this study, this is the treatment protocol which we would follow the study results out of Madurai. Why is this more interesting? Because in the UK at that point of time, they were manufacturing voriconazole. They were not manufacturing natamycin. So in fact, it costed them a lot of money. For 11 full months, they had to import natamycin from Canada. based on one study from a small city in Tamil Nadu. So that is the power of doing a well-done research study where you can influence global ophthalmology, where people respect you for the rigor of that study. So to just, in conclusion, for this part of my talk, there is a considerable variation not only between the fungi of two different genera, but within the species also there is a difference in virulence. There is a differing host response to different fungi. Killing the agent does not mean that you're controlling the disease. It is just smirking. Sometimes it just dies off, but that is not the way when it establishes itself. In early disease, you can escape, but an established disease, you cannot. So you need to have topical selective immunosuppression. If I had used the last sentence in a podium, either in the US or in India 10 years back, I would have been asked to get out of the podium and not come back for another 10 years. But now people understand the importance of it. They definitely are looking for selective topical immunosuppression. We are not talking of steroids here. We are talking of topical MMP suppression. We are talking of topical IL-17 suppression. That kind of a selective suppression is what is going to be the future. So another thing which always bothered me, I'm going to veer away from the scientific part of this topic, is as scientists, we have done all these things, but how do I help people who are actually coming to me at this point of time? How am I able to help people who are able to come this? And so I go with I have written a textbook which gets sold pretty much across the globe. And I get a royalty of a significant amount from which we've done a project. I have a 2-minute video which describes about this project. I'm very, very proud of this part of my work, which will not get published any place. But it's just to show you, as a clinician, it's not only our responsibility to do proteomics work, it is also our responsibility to take care of the patients who come to us today and tomorrow. I'm just going to show you this video, which has some sound in it. I hope the sound also will come. Okay, let me try.
பாட்டி இந்த மருந்தெல்லாம் போட்டுட்டு 2 நாள் கழிச்சு எங்களை வந்து பாருங்க சரியா?
A healthcare provider's responsibility does not stop with diagnosing the condition and offering a prescription. Aravind, along with partners like GBS, goes an extra mile and gives free medicine and money for transport of patients and attenders till the ulcer heals.
Over a period of time, I came to realize that a prescription never cures a disease. You can have all the resources in the world. You can have all the intellectual knowledge. You can have all the results from a clinical trial. Effective implementation is the key. And I came to realize that without implementation of the knowledge, it just doesn't mean anything.
Instead of that expensive prescription, which they all feared, free drugs were directly handed to the patient, along with the money to meet their travel expenses. This encouraged them to come for regular follow-up and put life back on track for Thenmuli. Even the junior-most staff at the clinic is given the freedom to educate such beneficiaries about the treatment schemes. The quality of giving is ingrained into every member of the team.
Thank you so much for the entire Aravind Eye Hospital team.
கொஞ்சம் கண்ணு மாற்றியதுக்கு அப்புறம் பார்வை கொஞ்சம் நார்மலாக நல்லா தெரியுது.
Ultimately, it is faith that cures.
What it effectively means is we have flooded those families with optimism, with courage, and we have also stood by them during this time of crisis, especially in the whole era of pessimism which surrounds their everyday life. And it often reminds me of Dr. V's words. He used to often say, it is ourselves we are helping, it is ourselves we are healing. It's a very, very nice feeling to have for me. So this was something which was very close to me because the results of my trial is going to be, certain things have happened, certain things are going to happen 10 years from now, but I thought it was my responsibility to sort of raise money, and we are now able to give treatment and also more importantly, be able to give patients money to come for follow-up so that you are able to heal their ulcers before this thing. So for this part of presentation, I would like to acknowledge all my investigators from all the centers of Aravind and also our long-term partners, Proctor Foundation at UCSF, at Dartmouth, where we have a collaboration with the Photography Reading Center, the Kellogg Eye Center, where we are designing this AI machine, and also the University of Edinburgh, where we are working with pulmonologists, where we're trying to develop these chemical probes, which will light up with their inflammatory and infective markers. Aravind has actually benefited a lot from these international exchanges. One of the typical example in this is Dr. Alan Robin, who came to Aravind when we were so primitive in doing research. And I really would like to invite each one of you to visit us, to help us, to collaborate with us, and to have a very, very open mind towards this thing. I'm really concerned that the books tend to keep us thinking this way because it is they also don't want to put controversial things. It takes a lot of time before it comes into the press. But if you are able to collaborate with people, if you're able to talk with people, then the conversations get refined. And so probably one of you would develop that topical immunosuppressor for me. So with this, my first talk of the 3 talks comes to an end. And this is again a quote which often Dr. V often says, there must be a joy of doing something beautiful. Not everybody gets a chance to be in a profession like ours. And it's also diplomatically wrong today to be so exuberant. But I always say controversial things and escape by saying English is not my first language. But I precisely mean what I'm talking. And there need not be too much of diplomacy in everything. That really blunts the whole picture. So I finished my first talk. You want to give a break?
Sure. Yeah, we'll take 5 minutes.